What was the previous size of the gallbladder polyp? Previous size, there is a previous report, no?
polyp
5.2
into 7.
Any comment on the enhancing or whatever?
No, sir.
No comment.
In the-
So what is the protocol for management of a gallbladder polyp? What do we do?
So single sessile polyp, which is more than 1 centimeter in size, there is a high suspicion of malignancy in that. So we have to go for cholecystectomy in that patient after imaging.
He's saying single sessile, more than 1 centimeter, gallbladder polyp is a risk. What do you say? This is a young bureaucrat. She is functional. There is no problem with her daily activity. So,
Sir, generally multiple polyp with multiple sessile polyp.
there is a rule of one which we used to follow. Although any patient in endemic zone with that kind of a suspicion, we should go for cholecystectomy. Endemic zone of carcinoma gallbladder, which is the Gangetic plane, right? So there is a risk of developing carcinoma gallbladder in these patients with or without stones, and this is a gallbladder without stones. So without stones, if you're looking at a polyp, sessile, more than 1 centimeter, and with some features of irregular thickening, or you can add a vascularity part to it. It's more vascular than you suspected.
Yes, sir.
Is that okay? So
Yes,
don't
sir.
just casually mention things without thinking about it. It can be a problem.
Yes, sir.
And stone, which one is a better modality, ultrasound or CT?
So for stone, it is ultrasound, sir.
Sir, ultrasound is the best modality for gallbladder.
Because they can be non-calcific. They're mostly, CT is nothing but an X-ray. So this mistake should not be done. CT doesn't make it, it's not always a very sophisticated modality. So the investigation or the modality of choice is ultrasound for gallbladder CVD stones.
Yes,
CT
sir.
is only required for, this probably was done because of the thickness. And this patient has been in regular follow-up because was not willing for cholecystectomy initially.
Yes, sir.
And considering that there is no change in size, in fact, you find the size is just slightly less than last time, but there is a little bit of enhancement. I would counsel the patient for cholecystectomy if she has got no other reservations. But it's not a good idea to say surgery for everyone, because everybody doesn't develop cancer.
Yes, sir.
And what is this Gangetic plane theory? Shagun?
So,
Sir, Gangetic plane theory is the Gangetic water has some minerals which are like arsenic, which are suspected to be carcinogenic in nature.
There are multiple theories actually. One theory is, of course, the metals, heavy metals in the river, because as it comes downstream, there is a lot of contamination, pollution. Heavy metal and industrial waste. Then there was also a publication from around Varanasi by, I think, the team of Dr. Shukla, where they talked about the kind of oil these people consume in their food. It is not something that can be substantiated, but they did propose that theory. And then me, along with Dr. Deepthi Nair and Malini, we looked at all the cholecystitis patients, we looked at the biofilm. But that was around 15 years ago that we did that study. And that biofilm around the stone, because stone is not without infection. Like I taught the other day, it's a tomb raised in the memory of bacteria that are lying buried underneath. So it is a mixture of many things. But the incidence is high amongst patients living in the Gangetic plains. Rishi, since you've come, any thoughts on the management of a gallbladder.
So
Yes,
GB
sir.
polyp size greater than 1 centimeter. Second, the wall thickness is greater than 4 mm and increasing on the serial scan.
Which is more than 1 in number, more than 1 centimeter, sessile, and thickness of the gallbladder wall more than 4 mm, but increasing. Enhancement alone is not an indication. So we can observe these patients, but I was just telling them about the endemicity along the Gangetic plain. Do you know the Indians living in Fiji? They also have a very high incidence of carcinoma gallbladder. That means it's got to do with the race also. There's no Gangaji there. So how do they get it? So there is some connection. Indians living in Fiji, they've been found to have carcinoma gallbladder. Down south, carcinoma gallbladder is not so common. It's common in the Gangetic plain, increasing as it, the river goes downstream. But by and large, you can convince a patient about, getting the cholecystectomy done, which doesn't mean that you'll always. We saw the other day we operated. She was with me. Radical cholecystectomy. That patient was detected early, so we could do a radical cholecystectomy comfortably with good clearance. So that can give. It's basically a surgical disease. So don't rely on chemotherapy or any other modality. So a radical surgery done at the right time, which means clearance of all the, starting with the etoportocable node up, peridocal, porta, hepatis and gallbladder, and taking a margin of 1 centimeter. That's what we did in radical chole, and we can achieve a reasonably good outcome. There's a patient of carcinoma gallbladder that we operated 4 years ago. She's alive because it was detected early. But otherwise, it's a deadly disease. Progresses very, very rapidly. That is why the patient is scared. The patient has no family history. There is nobody in the family with any cancer. She's absolutely a family without cancer of any kind. So there is no reason to scare the hell out of her. She's a bureaucrat, busy working, taking care of many things. So we can counsel her. We can do serial CTs, as Dr. Rishi was also saying. We've done 3 and the size remains constant. She can be observed, absolutely asymptomatic, we can observe. But the indication for cholecystectomy is not presence of gallbladder. This is a major problem. The indication for hysterectomy is not presence of uterus, which is what you see in the, with due respect, in the rural areas or places, B city, B town, etc. This is the wrong thing. Oh, iske appendix nikalo. So we preserve even appendix. What is the concept on interval appendicectomy now, Shugun?
Sir, it is not very widely practiced now, sir, because these patients can be managed expectantly.
And sir, some patients have single episodes of appendicitis, and then after that they have not any other further episodes. And appendix is considered to be it is a lymphoid organ, so it is helps in
Very good point, yes.
Yes, sir. Better to
You
preserve
agree, no?
rather than, yes, sir. Even
So it's not something we should do like we used to do.
so even patient is planning for pregnancy in a female patient. It is not now.
That it was taken as a vestigial organ. Now we know that it is not.
Yes.
There is something about belly which is connected to the, this whole idea of the appendix, appendices, epiploicy, all these are important organs. There's nothing in the body which is a waste. It cannot be. Nature is not foolish. We are.
Yes, sir.
So taking a decision about, prophylactic appendicectomy was what done in patients going to space, or to Mount Everest or Antarctica. In fact, one appendicectomy was in Antarctica. You know what? A Russian surgeon did his own appendicectomy looking at the mirror using local anesthetic. It's a record. But now they have surgeons also. In their camp we have, even the Indian Army surgeons go there. So now it is possible. So astronauts, people going to the mountain top, they were all earlier. This was done, but it's not a vestigial organ. And similarly, gallbladder shouldn't just be removed. That's also important. And you should not scare the patient each time with the, with the atom bomb, that is carcinoma gallbladder every time. Everybody doesn't. But yes, if there are stones, then the possibility is even higher. because 90% of the gallstones, 90% of the cancers of gallbladder are associated with gallstones, although they are not directly causing. For that reason only, I was saying that paper with Dr. Deepthi Nair that we did, which had biofilm concept. So how are they connected? Because coexistence is so unique that there has to be some causation, but could not be proven, because if stone was to produce the cancer, it will produce metaplasia and squamous cell carcinoma should happen, like it happens in the kidney with the stone irritating and but it is adenocarcinoma. So that means stone is not directly causing it. It could be coexisting. So both factors. The bile becomes carcinogenic in that case. Where else is what cancer incidence rises with cholecystectomy?
So colon cancer,
So because bile is considered
carcinoma.
So every surgery has its impact. Plus one, the surgery, and then. But if the patient is very anxious and not willing to take your advice, or if she's too scared, maybe then you can do it. Right? Clear?
Yes, sir.
So.
Sir, what should we do, say, a patient of suspected appendicitis clinically?
That's okay. Oh, what suspected appendicitis? If there is patient who has
Patient-
appendicitis,
yes,
we
patient has
operate naturally.
Appendicitis, we open the patient
No, that's,
and we see that the appendix is normal intraoperatively. Then, sir, what should we do?
It's a kind of
No, basically you had a very high clinical suspicion of appendicitis, but you opened up and you found appendix is normal. That is water lily,
Yes, sir.
nice looking, good looking appendix, right? That's what you're saying?
Yes, sir.
You're looking for the villain, you found a hero. Now where do you search for the villain now? So one answer is you trace back 1.5 foot to look for Meikles. If it is a lady, look for the Michelmer's, that is ovarian follicle rupture, blood collection, because it produces exactly the same picture. Blood irritates, produces peritonism. So patient has all the features of appendicitis, which you clinically have, symptoms and signs both. If you find nothing still, so naturally you made a wrong diagnosis. Look for the lymph nodes, mesenteric lymphadenitis, especially in children. Right? And whenever in doubt, look for the worms. Because tuberculosis can mimic everything, including pregnancy. And worms can mimic almost everything, excluding pregnancy. Because pseudocyesis, amenorrhea, etc., that is tuberculosis, can mimic that. So worms are a possibility, but I'm not suggesting that that's on, because sometimes the worms go block the lumen and then come out of it. Then also there is a term called appendicular colic, where there is an obstruction which gets relieved. It's a tube. Basically, appendicitis is also an obstructive disease. No, there is an obstruction at the base by the fecolith, foreign body, malignancy, worm, whatever. And then there is a mucocele, because the mucus collection which gets in, which keeps on increasing in size, applying pressure on the veins, which leads to more edema of the wall, which leads to more pressure on the vein, more edema of the wall, finally arterial, and that's. Wherever there is stasis, stagnant water is dirty, flowing river is clean, remember that. So if there is stasis, there will be infection, and that is what it will lead to. Suppose you opened up and you found a lump. You not opened up, under anesthesia also you are supposed to examine, right?
Yes, sir.
When you find a lump, you abandon the procedure. If the patient was otherwise stable. But lump doesn't mean good news always. Appendicular lump can be a resolving appendix or evolving abscess.
Yes.
I've seen people getting into the disaster of opening up when it's a resolving appendicitis, or not opening up when it's a evolving appendicular abscess. So therefore one has to be clinically sharp, and in this case maybe you can use your ultrasound to effect. Don't use it to make a diagnosis of appendicitis, although it is used with the double lumen test and pressure on the bigger circle, the smaller one distance if there is no obstruction. If it doesn't, then you suspect it to be appendicitis. So by and large, the answer to your question is have a good clinical judgment. Good ultrasound, since we have an extension of clinical examination is ultrasound. But suppose the patient had a resolving appendicitis or a lump, then Austen-Scherin regime. Do we do surgery after 6 weeks? That was the question. Whether we do interval appendicectomy or not. For that, there is a meta-analysis which was published some years ago that you don't need to. A lot of them don't develop appendicitis. They looked at how many developed it. So if they're not developing, why should you bother it? But if the patient has come again with appendicitis, keeps coming back with symptoms, you can operate. But in good time, when you're clean, you have time, you can do laparoscopic appendicectomy, minimal morbidity, etc. And always split open a specimen. Rule out a carcinoid. It is not as rare. Rare things are rare because we don't think about them. We make them rarer. How do you make something uncommon? Don't think about it, it will become uncommon. So have that suspicion in your mind. You saying
And
something?
sir, yes sir, prophylactically, why when you are doing the lab procedure in the malrotation of gut especially, so if there is a further suspicion of appendicitis or during the clinical course, better to remove intraoperatively appendix at that time. One of them is.
Like we have prophylactic surgery for breast cancer, we do bilateral mastectomy and oophorectomy. You better have very strong reasons. With malrotation, why is he saying it is because you don't want some confused person somewhere in backwaters to open up and not find appendix and then hang around.
And the
The pain
location,
would still be referred to the umbilicus, but it'll get localized to the wrong side. And he'll be confused. So it is just to reduce the confusion of the next person. Otherwise, this person carries a placard wherever he goes that I have my malrotation of gut. That he cannot. No? Airport placard लेके जा रहे हैं कि साहब हमारा malrotated gut है. सबको थोड़ी बताएंगे. So this is a surgical common sense which you must have to be able to do a good job of surgery. Okay.
Yes, sir.
Yes, sir.
If you find carcinoid, what do? If it is within 1 centimeter of the base, or if it is more than 1 centimeter, we do right hemicolectomy. If it is less than that, we can do appendicectomy. And some people take a wide excision of the cecal base, send for the frozen section of the margin. It's an issue. Carcinoid is not not something that you are worried immediately about. It's a carcinoid syndrome that you're worried about. It's not immediately that you're bothered. But sometimes in the garb of carcinoid, you shouldn't be missing an adenocarcinoma. Therefore, look for lymph nodes. If it is looking like adenocarcinoma, see how much it is based on the judgment of a surgeon. Don't just throw it. The appendix should be opened. Because if it is an adenocarcinoma, then you have to do a proper right hemicolectomy. So in both situations, the answer remains that you will be open here. Now, what do you say about the brain? It's like a parachute. It only functions when it's open. Have you seen a parachute function when it's not open? Yes?
Yes, sir.
So keep your mind open. A surgeon is a thinking physician, intelligent psychiatrist. You don't have to be a pathologist, of course, be that somebody is doing. And I would read my CT. I would not read a CT that a radiologist has reported. Therefore, initially you brought the report. I'm not interested. I want to see the film myself. And every surgeon should be able to read his own imaging. Because imaging gradually, I think in the near future, you would not need a radiologist. Because head and neck surgeons, hepatobiliary surgeons, breast surgeons, they like to see their own image everywhere to plan resection. And they would prefer 3D, good images. A radiologist who's sitting, say, in a journal radiology, then he goes to breast radiology, he's reporting more or less, it's more monotonous. If you read it, correlate it clinically, there is an enhancement. As soon as there is enhancement, tell me about the blood supply. Because I'm not bothered about your report, because the radiologist report doesn't treat people. You have to understand whether it is malignancy or not. That's what my question is. My comment on the lymph nodes, if they are present or not. This is what is going to contribute to the eventual clinical outcome. That is why it's important. Is that okay?
Yes.
So about a gallbladder polyp case we were discussing, but we covered up appendicectomy, interval appendicectomy. You don't need to plan. So interval appendicectomy is no longer recommended. Prophylactic appendectomy in malnutrition is basically to avoid confusion. And in a lady, you know what? There used to be a teaching earlier. If you've done 100 appendectomies and if you have not taken out 20 normal appendectomies, you have not done 100 appendectomies. Which meant invariably you'll find that you will remove. Clinically, they were judging. Today, I think it should not be acceptable. You should not, you've got no business to remove a normal appendix. It's a normal functioning organ. The other day I was teaching about the autocorpophagy and you guys were giggling away to glory, but you realize that it's an important organ. It used to be so important. Brain has undergone many changes. That doesn't mean that part which is not functional, you won't. You know, speech has grown over gestures. So, a very interesting observation in patients who have a CNS damage, right? What do they lose first? Speech. They lose speech, no? The gestures remain. When they recover, what do they get first? Gestures. It's exactly like how we evolved. Then if you go from the basic, if you just analyze brain only, you have the base medulla oblongata and you go up, the midbrain, and then you keep going up. Where are the basic centers of life? Here. Then thalamus, hypothalamus, limbic system, emotions, cortex, then supercortex. Now Homo sapiens have got it. So when you lose it, you lose the reverse way. Otherwise, you would be dead before you lose your memory. You don't have to lose your memory once you're dead, right? You lost it. So the nature evolves that way. It is the life factor which comes first. So when you're losing it in herniation of brain, we all read it, no? Initially the level of consciousness is gone. Then thinking is gone. Pehchan nahi raha hai, Shagun, Ram, isko, Rishi, senior Rishi. You're not recognizing. But gradually, this also goes, and then you're on ventilator because even the respiratory system, basal system, they are going. Because the nature has put it in such a way that the last to go is what you got first. So this is a principle of neurology, of brain. There is a beautiful book and you people should read, Shagun and Rishi, The Garden of Eden by Carl Sagan, Ascent of Man. There are some books which are interesting. So then that's not about this, but I'm generally trying to put them together. So as we evolved, the brain evolved. So if you study the brain, your evolution is understood. The basal life stayed where it is, and then you evolved. Limbic system is a feature of, you see in apes, na, emotions. You don't see that in, you see patchily in all, when mother everywhere is the same, but gradually even that mother is not bothered about this boy or this whatever, because this is where we evolved and we are different. So therefore coming to the surgical understanding is not just about how do you cut, it's about when to decide about it, when not to cut, when cut, how to cut, how minimum to cut, how to stitch it back. And even before you start your surgery, think about completing it and coming out of it. It should not be like Abhimanyu, with due respect. What are the basic flaw in Abhimanyu's life? He kept on talking, and we keep reading up in Mahabharata about this, right? He learned how to get into the Chakravyuh when he was in womb. Then the mother went to sleep. Arjuna was telling the story, but Subhadra went to sleep. So Abhimanyu did not learn how to come out of it. But isn't that stupid of him? He woke up, he was born. His father was there, he could have asked him. So to stay ignorant just because you were, I come from so and so place, I come from so and so background, I am so and so how can I learn it? That is your fault. So what are these, teaching ways to acquire, to get into the Chakravyuh and come out? CMEs, lectures, going to a teacher, because he could have done it. Abhimanyu was literally brought up by Lord Krishna. So he could have asked him, please teach me about how to come out, because that part I learnt in my first prof and second prof. Now teach me in the final prof. And that is exactly how you students get trained. वो तो फर्स्ट प्रॉप में पढ़ा था ना, anatomy, physiology, biochemistry, because that's how it is taught also. And they'll start learning about their clinical subjects only when they reach their final year, which is a shame. Clinical subjects is all about your training. Rest is all helping you become a clinician. What is helping you to become a clinician cannot be a specialty. It can be a specialty. Like Shagun is cook for today, he's a chef. कोई इसके लिए प्याज काट रहा है, कोई मिर्च काट रहा है, कोई वगैरह, बट वो सब तो ये कर रहा है ना. द एक्चुअल थिंग विद अ हेलमेट ऑन ही इज डूइंग. सो suddenly this Mirch fellow has become very important. Then the other guy who, what do you call him? The one who...
Always.
It's not always a butcher. It's not non-veg always. There is a chap who is assisting the cook now, and there are good number of them. So that's his team. Call them, one doing the X-ray, the other doing the testing of the taste of the material, but he's the one who's cooking. So you want to be the super cook or you want to be one of those masala cheese? Now I get the word. So be one who can. It's good to learn all this so that if that fellow doesn't come that day, you can do it yourself. That is exactly. I don't know how did this analogy come, but this analogy fits in very well. I suddenly realize as I'm talking. So don't just I want to be a specialist at cutting the vegetables. It's a very good thing to do. Very good thing. You can be doing it, but if there's no cook, what will you cut the vegetables for? You can ask a question, if there's no vegetable, what will you do with it, right? So if there's no patient, what are you going to treat? So this guy comes into business when you are in business, not the other way around. So become the one who drives it, rather one who is helping it go. I was discussing in probably the last some student was talking about the guy who topped in, the student who topped in NEET. Less input, more output. Sabzi kaat ke kaun sa input hoga, wo to the cook has to decide what is to be going to happen. So when you're making the pudding, you take the help of all sorts of people around you. All these blighters contribute to what you're cooking and making. Eventually, it's the taste of the pudding that decides how good it was. Importance, everyone is important. But don't just for this sake choose the path. If you enjoy cutting the vegetables, it's a good idea. If somebody wants to just be smart at one part of a profession, there's nothing wrong in it. And don't take it for that reason. Giving you if somebody doesn't like to be operating, doesn't like to be the operation theatre or faints in the operation theatre, it's okay. As the day, all specializations are good. Everything is good. But don't take a decision based on less input, more output. Take a decision based on what you enjoy most. So while I was talking to you about the gallbladder polyp, interval appendicectomies, cancer gallbladder, and what else? Carcinoid of the appendix. Is that the benign carcinoid, the most common site is appendix, right?
Yes, sir.
But malignant is intestine.
Yes, sir.
Am I right? GIT?
Small intestine.
Small intestine is what I'm saying. So carcinoid syndrome would happen with small intestine, because even if there is a metastasis to the liver, it may not produce carcinoid syndrome, which is different from carcinoid tumor. So the two have to be understood. But take up
syndrome.
CVD injury by just seizures or by carotid done will be happens. So how can we manage CVD injury in that scenario? So in both different cases. So if
you detect it peroperatively, the approach is to get help from someone who can handle CBD. The options would be many. Every CBD injury does not require hepatico-jejunostomy. But somebody who is repairing the CBD should have a good knowledge of the anatomy of you saw the other day, radical cholecystectomy and the anatomy of porta hepatis. Artery is anterior, A for artery, duct for dextral right, P for portal vein posterior. Now, small rents can be repaired without having a T-tube underneath. They can be repaired by simple interrupted sutures using fine needle and fine suture. CBD should be considered as delicate as a vessel. So do not use crude handling. Why am I saying somebody who's not trained should not handle it? Because each time that you treat it, the stricture would form and it will keep going higher. And if it goes higher, it will become difficult to, handle it. So it is better to let an expert. But if you are not trained to handle it and you have no expert available, you should not attempt doing fancy things. Leave a drain, refer to a center where this repair can be done. It is acceptable treatment. It's not considered criminal. It is criminal to do what you don't know you have not been trained to do. Second one is the scissor injury is better than the diathermy injury. Because diathermy injury could even have prolonged late effects. You do not know where the diathermy is damaged. You can have pseudoaneurysms of the hepatic artery, cystic artery, or the damage that is visible could be less than actually the damage that has happened, because conduction effect is very much. Coupling effect, conduction effects, so all to be taken into account. But the protocol remains just the same. Right? So,
Yes.
but importantly, choose wisely, but use it with your heart, not with your brain. Don't calculate कि सब्जी काटने के ज़्यादा पैसे मिलते हैं तो सब्जी काटते हैं. बनना कुक है आपको, अगर सब्जी काटने का शौक है तो अच्छी बात है. कुछ लोगों the people enjoy that also. Nothing wrong in it. If somebody wants to be teaching anatomy, reading anatomy, good luck. But then he cannot come and claim about, I'm treating patients, although they are dead. There's a difference. You have to be mentally at peace. You should understand what you're doing. No subject is more important than the other. The best thing is to ask the patient, which is the best subject, what subject is more important for you. Obviously, he will say where I get treated is what I matter. They will ask me who the radiologist to go to, the pathology. They won't ask a radiologist where to go for a clinical treatment. So it's always the responsibility that you want to take. If you want more result, more authority without responsibility, you're failing. You're faking. You can't be getting it. Every responsibility comes with authority, comes with responsibility, or it's a dummy. Somebody's trying to fool you. It has to come with responsibility. And where is the problem? Take responsibility and take care of. Because when you're in control of things, you can handle them, make them better. Okay?
Yes, sir.